Welcome to MedStuff. In this video, I am going to talk about depression. Depression has been one of the most frequently heard words during this pandemic. Why is it so? This pandemic has caused sudden changes in our lifestyle due to restricted movements, low social interactions, low income, financial crisis, unemployment, and many more stress factors affecting our mental health. This leads to mental illnesses. Among all the mental illnesses, depression is the most common one. Okay, so now what is this depression? It is a kind of mood disorder in which a person has persistently low mood for over a period of time. That is, if the low mood persists for 2 weeks or more, then it is called as depression, or more precisely, it is called as clinical depression. It is also called as unipolar disorder or major depressive disorder. Depression is a kind of vicious cycle. Let us consider, for instance, if I have more stress due to work, this leads to low mood at some point of time. If this mood persists for a longer period of time, then it is called as depression. Let us say for a minimum of 2 weeks, as we have discussed before. This depressed mood affects my daily functional activities, causing low productivity in my work too, making my life much more pathetic. This lag in the work may increase the stress on me from my higher authorities like my boss, causing more stress on me. This may lead for another depressive episode, and hence the cycle continues. Depression is considered as the most burdensome psychiatric illness because it affects our functioning of daily activities, causing burden on ourselves. It is also a most common psychiatric illness that is seen in 5 to 15% of general population. It has recurrent property, that is, a person with first depressive episode has 50% more likely chance to get second episode, and a person with second episode has 75% likely chances to get a third one, and person with third episode has 90% chance to get many such episodes, showing its recurrence property. About 10 to 20% cases are resistant to medication, that is, do not respond well to treatment, as the exact mechanism of depression is yet to be known for effective treatment. It is also the most disabling illness, as 10 to 15% of depressed cases have either suicidal tendencies or might have attempted suicide or have actually lost their lives by suicide, that is, disabling their lives. Now, let us go deeper into our topic. In this video, you will know when do we call it as clinical depression? Is merely feeling depressed considered as clinical depression? In whom do we see depression more likely and risk factors causing it? Where does the defect lie? What are the symptoms, levels, and subtypes of depression? Why do we get these symptoms in depression and mechanism behind it? How do we diagnose and treat a depressed patient? Okay, let's begin with our first question. When? When do we call it as clinical depression? For instance, I had a fight with my sibling due to which I have a low mood and feeling depressed. Right after some time, my dad got something nice for me which lifted my mood. Now I'm happy. Does this mean I was in depression a little while ago? No. As I have already said, to consider it as a clinical depression, mood must be low persistently for over 2 weeks or more, during which any previously pleasurable event does not lift their mood anymore. So feeling depressed for a little while doesn't mean that you have actual clinical depression. Clinical depression may last from 1.5 months to even 1.5 years with frequent episodes. Moving on to next question. Whom? Who are more susceptible to depression? There isn't any age limit. All ages are susceptible to depression, but teen and adolescent ages has greater ratio compared to other ages. Considering gender, females are more prone than males, that is 5:2 ratio. For other contributing factors of stress leading to depression, biopsychosocial understanding is necessary because depression results due to a complex interaction between biological, psychological, and social factors. Let us know these factors in detail. Biological factors leading to depression. A person with family history of depression is susceptible to depression. In elderly persons with neurodegenerative disorders like Alzheimer's and Parkinson's and etc. are susceptible. Underlying medical conditions like cancer, hypothyroidism also may lead to depression. Psychological factors. Among psychological factors, most important one is cognitive triad of depression. It includes hopelessness, helplessness, worthlessness. Person loses hope in everything, do not seek any help from people, feels so worthless that he has no purpose in life. Another psychological factor is bereavement. Bereavement means death of a very close person or loved one may affect psychologically. Introjection, that is, incorporating others' views into oneself. For example, if someone says that the mistake happened was because of you, then you incorporate that guilt on yourself. Perinatal stress, that is, stress during or after pregnancy. Trauma, any accident or incident that you have witnessed haunts you, leading to low mood and depression. Social factors. First one is unemployment and caregiver burden. Due to no income, you feel that you have become a burden on your parents. No social support, isolating a person for some reason. Marital conflicts, divorce and widows. Any adverse life events. Work stress. Physical or mental abuse like rape and bullying. Interpersonal difficulties like difficulty to bond with others. Financial problems and poor economic background lead to stress in leading their families. Alcohol or drug abuse and relationship problems as seen in adolescent and teenagers. So these are all the biological, psychological and social factors. A person with any of these factors is susceptible to depression. So our next question, where? Where does the defect lie? The defect is said to lie within the neural circuits of the brain, that is, reduced neurotransmitters at the synapse. Exact mechanism of this is discussed later in the video. Our next question is what? What are the symptoms seen in a depressed patient? Mainly, there are three main symptoms. That is, anhedonia or loss of interest in everything, low mood, and third one is low energy, feeling lethargic. Among these, if any two symptoms persist, then it is also considered as depression. What are the other features? Excessive guilt or self-blame is seen excessively in about 40% of the cases. Appetite changes, either overeating or eating less. Sleep changes, insomnia or disturbed sleep or hypersomnia. Reduced concentration or attention in work. Reduced self-esteem or confidence. Psychomotor agitation, that is, unnecessary movements like tapping toes, rapid talking, etc., seen in bipolar disorder. Dysfunctionality either in work or self-care. Cognitive symptoms like reduced ability to understand, process, and respond to information. Anger and irritability in kids and teens with severe depression. Rumination, that is, repetitive thoughts of being worthless. And the last one, suicidal thoughts and tendencies. Persistence of any 5 or more of these symptoms for over a period of 2 weeks or more is considered as clinical depression. Then, what are the levels of depression? Based on the severity of symptoms, there are 3 levels of depression: mild, moderate, and severe. Mild form has symptoms, but vegetative symptoms, that means symptoms that directly affect our life, are absent, and dysfunctionality is also absent in mild form. Mild forms are usually treated with psychotherapy itself. The treatment is explained detailedly in the next video. Moderate forms have symptoms and vegetative symptoms, but the functionality is still not affected. Such cases are treated with antidepressants. Severe form has symptoms, vegetative symptoms, and as well functionality is affected. Such cases are treated with antidepressants and therapies. Psychotic symptoms can be present in moderate and severe levels of depression. What are the subtypes of clinical depression or major depressive disorder? Persistent depressive disorder or dysthymia, bipolar disorder or mania depression, perinatal depression, anaclitic depression, atypical depression, melancholic depression, psychotic depression, seasonal depression, and late onset depression. Let us know each of these in detail. Beginning with dysthymia. Dysthymia is also called as persistent depressive disorder. It is a little abnormally low mood for over a period of time. It is initial stage of depression but not actual depression. Such people are vulnerable to depression in future. A dysthymic person has symptoms similar to major depressive disorder like appetite changes, sleep changes, fatigue, reduced self-esteem, hopelessness, pessimism, etc. They may not be suicidal or dysfunctional. Antidepressants are given to treat such cases. Double depression. Double depression is a state of dysthymia continued with depression episodes. Next one is bipolar disorder or mania depression. It is a kind of mood disorder in which mood fluctuates into mania and depression with normal mood intervals in between. Like this is mania, normal mood interval, and this is depression. In short, it is exaggerated cyclothymia. What is cyclothymia? It means cyclical moods, that is little low and little high fluctuations, like dysthymia has little low fluctuations. Symptoms of bipolar include both mania and depression symptoms. We already know depression symptoms. Mania symptoms are elevated mood, overactivity, fast speech, inflated self-esteem, decreased need of sleep, psychomotor agitation, etc. are seen. There are other types of bipolar disorder too, hence it is not entirely a subtype of depression. Contributing risk factors for bipolar disorder are family history or genetics, pregnancy stress leading to postpartum psychosis, psychological stress, substance abuse, disturbed lifestyle, and poor sleep rhythm. Management of bipolar disorder. For acute cases, fast medication is required, so mood stabilizers like lithium is preferred. Otherwise, antipsychotics are given. For prophylactic treatment, mood stabilizers like lithium, valproate, carbamazepine, and lamotrigine are given. Therapies like social rhythm therapy is preferred. Third one is perinatal depression. The depression during pregnancy or after childbirth, that is postpartum period. It includes postpartum blues and postpartum depression. Postpartum blues, also called as baby blues, is a benign, self-limiting and common condition seen in about 50% pregnancies. Women with baby blues become more weepy, irritated and stressed out after delivery. They also have sleep changes, like she cannot sleep continuously for so long. It subsides within 10 days to 2 weeks automatically. Hence treatment is not required. Postpartum depression. It is uniquely seen in both males as well as females. About 5 to 15% of pregnant women suffer from this. Onset is either peripartum, that is during pregnancy, or postpartum, that is precipitate between 4 weeks to 6 months after delivery. Such women may develop full-fledged depressive episodes in future. Contributing risk factors for postpartum depression are previous history of depression, poor marital relationship or marital conflicts, lack of social support, stress life, hormonal changes during pregnancy, lifestyle changes after childbirth. In males, if the person's wife has postpartum depression, then he has 25 to 50% chance to get postpartum depression himself. Symptoms of postpartum depression: mood swings, frequent crying, trouble bonding with baby, tiredness and restlessness, fear of not being a good mother, sense of worthlessness or shame, impaired decision making. Mechanism of postpartum depression. In women, progesterone maintains uterus during pregnancy. At the time of delivery, progesterone drops drastically and suddenly, along with other hormones like prolactin, estrogen, cortisol. These hormonal changes lead to postpartum depression. In men, mechanism of postpartum depression is similar hormonal fluctuations along with testosterone and vasopressin during or after pregnancy, which leads to postpartum depression. Management. It has to be treated with medications and therapies of depression. Medications like lithium is given, but has side effects like risk of Epstein's anomaly to baby and risk of lithium toxicity in mother. As there is more loss of blood during delivery, there is reduction in the blood volume in mother. Hence, lithium levels increase in the blood, causing lithium toxicity. Other drug is benzodiazepine. It has side effects like cleft palate, bowel atresia, premature birth, respiratory depression in neonates. Lamotrigine is a safer drug in pregnancies for treating postpartum depression. Antipsychotics are also given, and they are safer than antidepressants as selective serotonin reuptake inhibitor antidepressant causes respiratory distress in neonates. Therapies like cognitive behavioral therapy and interpersonal therapies are given to treat postpartum depression. This is all about postpartum depression. Next, anaphylactic depression. It is a kind of depression seen in infants or young children who are separated from their primary caregiver, that is mother, for a prolonged period of time. like in cases of mother's death or mother's serious illness due to which baby has to be separated, or any marital conflicts. Next one is atypical depression. Symptoms of atypical depression are a bit unique, like hyperphagia or overeating, which may lead to obesity, hypersomnia or oversleeping, interpersonal rejection sensitivity, that is, feeling of rejection or criticism from a very close one. In spite of them being good with us, we just have a feeling that they're trying to criticize us. Laden paralysis, heavy feeling of the limbs and do not want to move. They always like to lie on the bed. Mood reactivity. Mood is improved with pleasurable events. Unlike in actual depression, mood is not reactivated with pleasurable events. In this kind of depression, mood is reactivated. Melancholic depression. A person with melancholic depression has both symptoms of major depressive disorder as well as melancholic features. Melancholic features include loss of pleasure in all or most of the daily activities, lack of reactivity to positive news or positive events, deep feeling of despair and persistent guilt. Melancholic depression is mostly seen in people with severe major depressive disorder symptoms. Next, psychotic depression. Psychotic depression person has both symptoms of major depressive disorder as well as psychotic features. Psychotic features include delusions, like thoughts or beliefs that are not true but they believe it as true. Hallucinations, like hearing voices and feeling things which are not actually present. They also have psychomotor agitation, like unnecessary movements, and psychomotor retardation, that is slowing of thoughts and slowing of movements. It is mostly seen in people with adverse or traumatic events that have occurred in their childhood. Then, seasonal depression. A person with seasonal depression experiences depressive episodes during fall and winter. These episodes resolve in spring and summer, that is, it changes according to the season. Studies say that it might be due to circadian rhythm alteration or sunlight exposure, but particular reason is still a matter of research. And the last one is late onset depression. It is seen in older people about age greater than 65 years who did not experience any episodes of depression previously. So these are the subtypes of depression. Remaining why and how are continued in part 2. Thank you for watching.